Hi everyone, our subject today is hypotonia in the older child. Basics. Weakness is generally a complaint of older child. Young infants are more likely to present with hypotonia than weakness. Although the two frequently occur together, they are not synonymous. Active tone is physiologic, resistant to movement. Passive tone is range of motion around joint. Hypotonia is a reduction in joint resistant to passive range of motion. Weakness related to strength of or power or generated by muscle. Any component of the nervous system may be responsible. Brain disorders are more common in hypotonic infant, whereas neuromuscular disorders are more likely in older children. Feeding and developmental history is relevant in the assessment of older infant and toddler. For the older child present with the weakness, inquire about fatigability, falling, school, cognitive performance, and the possibility of ingestion, as well as family history. In toddlers and older children, strength can be assessed by observation of various tasks: standing on one foot, running, climbing stair, rising to stand from sitting or lying position, Gawarsai. How to approach the child with weakness in older, of course, not in infant. After performing history and physical examination, is there associated sign of symptom of illness, hypotonia, weakness, not predominant? If it is yes, this is heart failure, failure to thrive, renal failure, inborn error of metabolism, other metabolic disorder, rickets, scurvy, sepsis, and other infection. If it is no, consider creatinine phosphokinase, EMG, muscle biopsy. According to the site of weakness, if it is a proximal weakness, differential diagnosis, spinal cord disorder, juvenile spine muscular atrophies, myasthenia gravis, acquired, GM2 gangliosidosis, myopathy, muscular dystrophy, Duchenne, Becker, facioscapulohumeral syndrome, limb girdle dystrophy, inflammatory myopathy, dermatomyositis, metabolic myopathy, carnitine deficiency, endocrine myopathy like thyroid disease. If the weakness correlates with the specific spinal level, obtain MRI of the spine, differential diagnosis, spinal tumor, spinal abscess, and transverse myelitis. Is the weakness generalized? If it is yes, if it is acute onset or chronic. If it is acute onset, is there change in sensation present? If it is yes, this is either Guillain-Barré syndrome or tic paralysis. If it is no sensory changes, consider creatinine phosphokinase, EMG, muscle biopsy, lumbar puncture, differential diagnosis, acute infectious myositis, enterovirus, West Nile virus, tic paralysis, neuromuscular blocking agent if prolonged use, organophosphate poisoning, botulinum toxin, corticosteroid, high dose, acute intermittent porphyria, and hereditary tyrosinemia or periodic paralysis. If it is chronic, gradual onset, differential diagnosis, metabolic disorder, hyperthyroidism, congenital syndrome like Prader-Willi syndrome, Down syndrome, Soto, Angelman, Noonan, Rett, Smith-Lemli optis, or congenital hypomyelinating neuropathy. If it is distal weakness, differential diagnosis, Guillain-Barré syndrome, neuropathy, hereditary motor sensory neuropathy, Charcot-Marie tooth, other genetic neuropathy, neuropathy with systemic disease like systemic vasculitis, uremia, drug-induced toxin, idiopathic neuropathy, tic paralysis, spinal cord disorder, motor neuron disease, juvenile amyotrophic lateral sclerosis, spinal muscular atrophy, myopathy, hereditary distal myopathy, myotonic dystrophy, scapulohumeral, scapuloperoneal syndrome, endocrine myopathy like thyroid. Proximal leg weakness, wasting, and cramps are typical the initial manifestation of GM2 gangliosidosis, an autosomal recessive disorder of hexosaminidase A deficiency, with several phenotypic variants, including Tay-Sachs disease. Duchenne muscular dystrophy, an X-linked recessive disorder, is most common type of muscular dystrophy. Diagnosis is usually in late infancy or early childhood when a child presents with the hypertrophic posture and Gowar sign, typically by age 3 years. Trendelenburg gait, muscle atrophy, and pseudohypertrophy of the calves subsequently develop. Toe walking and frequent falling are common. History of delayed motor milestone may be noted retrospectively. Duchenne and Becker muscle dystrophies are both caused by defect in muscle protein dystrophin. Becker muscle dystrophy has a later onset and less severe course. Genetic test for the dystrophin gene defect is diagnostic if the creatinine kinase is elevated and the clinical picture is consistent with the Duchenne muscle dystrophy. Muscle biopsy may be needed if genetic test is normal. It may be also useful in distinguishing between Duchenne and Becker muscle dystrophy. Guillain-Barré syndrome is an acute demyelinating polyneuropathy characterized by an ascending motor weakness and areflexia. Sensory and autonomic nerves may be affected. Respiratory compromise can occur if respiratory muscles are involved. The syndrome frequently follows an upper respiratory tract infection or Campylobacter diarrhea. Elevated CSF protein without pileocytosis is characteristic. EMG results are consistent with the acute denervation of muscle. The most common cause of progressive distal weakness are neuropathy, most of which are familial. Dysesthesia, painful tingling and burning sensation often accompany the weakness. Autonomic symptoms like orthostatic hypotension, gastrointestinal dysmotility, abnormal sweating may be present, and deep tender reflex are usually markedly diminished relative to the degree of weakness. Diagnosis of this disorder is by nerve conduction velocity study and EMG. Lumbar puncture and an evaluation of CSF may be necessary to rule out certain suspected infectious causes. For example, non-polio enterovirus may cause poliomyelitis-like disease. Several species of North America tick carry a toxin that can cause a paralysis clinically similar to Guillain-Barré syndrome. Tender reflex are usually diminished, sensation is preserved, but burning or tingling may occur. Scapulohumeral or scapuloperoneal syndrome have characteristic of both nerve and muscle disease. Patient present with the proximal arm and distal leg weakness. Transverse myelitis present acutely with hypotonia and weakness. There is an identifiable motor sensory level, impaired bowel and bladder function, hyperreflexia, and an abnormal Babinski sign. In children younger than 3 years old, spinal cord dysfunction symptoms develop rapidly, hours to day. In older children, the symptoms develop more gradually, days to weeks. Spinal MRI show abnormal signal intensity of the involved level and CSF examination show mild peliocytosis and elevated protein level, specifically myelin basic protein and immunoglobulins. In periodic paralysis, patients experience episodes of severe weakness, often followed by partial or complete paralysis. Episodes are usually related to hypokalemia or hyperkalemia and may be primary genetically transmitted or secondary due to endocrine, renal, or gastrointestinal causes of hypokalemia or hyperkalemia. Top tips. Examination of child with weakness should always begin with the observation, including the head, shape and size, face for dysmorphism, eyes for strabismus, ophthalmoplegia, skin and muscle for any lesion, atrophy, hypertrophy, fasciculation, and gait, waddling, ataxic, and whether there is difficulty in rising up from the floor. Remember that proximal muscle weakness, shoulder and hips indicate a myopathy, while distal weakness, hands, indicate a neuropathy. Myotonic dystrophy is an exception, with the weakness affecting the hands. Children with congenital myopathy are distinguished from muscular dystrophy by facial weakness and normal or mildly elevated serum creatinine kinase level. Both hypothyroidism and hyperthyroidism can cause proximal muscle myopathy. Patients with the Graves' disease may cause ophthalmoplegia. Red flag. In a boy with the inability to walk by age of 18 months, Duchenne muscle dystrophy has to be excluded by serum creatinine kinase. Children with periodic paralysis are normal between episodes. Later, these become more frequent, causing permanent weakness. Children with leukodystrophies may cause diagnostic confusion as they have both upper and lower motor lesions.